so that we can, all take information back. And there are others too, other legislators in the audience today who I think will also be interested to take some of this information back. I will try to accommodate folks with questions. I know Representative Greenlick had also wanted to join us by phone. I limited it though just for people who could attend in person. So thank you all for being here, being present. And we should probably get started because I know the Oregon Health Authority has a lot on their plate and a lot of focus on one of the topics that we'll be talking about today. So we'll start with coronavirus, and then if our friends from vets would like to leave, we'll then move into SB 889, which is our benchmarking bill. So we'll start with coronavirus. Yeah. Okay, thank you. Yes, so Director Allen.
Thank you for the invitation.
Of course. Thank you for being able to join.
I have ways and means.
I know you do.
Stay. Okay.
Yeah,
Okay.
stay till you can. Yeah, so we will have some folks who I think have different schedules and will be leaving.
Okay.
Good afternoon, Chair Salinas, members of the committee, and guests of the committee. Patrick Allen, Director of the Oregon Health Authority. I'm joined today by Dr. Dean Seidlinger, who is our State Health Officer and State Epidemiologist, and Akiko Saito, who is our Emergency Operations Director. Happy to be here and provide you a fresh update on the novel or new coronavirus called COVID-19. What we'd like to do over the next little bit is give you an overview of how we're approaching preparedness for the disease. Dr. Seidlinger will talk a little bit about the virus itself and some of the things that are important to know about it as we think about this. Ms. Saito will talk about the incident management process we've had underway for a number of weeks already and how that is morphing. And then you may have seen today the governor asked us to step up our preparedness activity another notch by convening a coronavirus response team, which met for the first time today and will be meeting weekly thereafter. So, and then we hope to leave plenty of time for questions that you might have. So first, I just want to emphasize very strongly, there are no cases of COVID-19 in Oregon today. We have had a number of people under monitoring, and I think Dr. Seidlinger will talk about that. And we've had a couple of people who have been tested based on their being in monitoring and symptoms that they exhibited. They both tested negative, and so the disease is not in Oregon today, and that means today the risk to Oregonians is low. Certainly that could change very quickly, and we anticipate that the CDC advises us this disease will become widespread. The hospitals and healthcare systems have scaled up their preparedness to be ready for the disease in terms of how they screen patients, how they will receive patients who may be symptomatic, and all those kinds of things. And we'll spend a little bit more time on that in detail. And then one of the things the governor asked state agencies to do is to review their continuity of operations or COOP plans, particularly with an eye toward staff absence due to disease or self-quarantine or those kinds of issues.
Thank you, Pat. And good afternoon, Chair Salinas, members of the committee, and guests of the committee. Thank you again for having us here. This novel coronavirus was first identified in humans.
Sorry.
Oh, sorry. My name is Dean Seidlinger. I'm the State Health Officer and State Epidemiologist. This novel coronavirus was first identified in December of 2009 in 2019 in Wuhan, China. And Oregon Public Health Authority, along with our federal partners and our local public health partners, has been following the situation closely since it was identified. In fact, on January 21st, 2020, we stepped up our incident management team, which drew from people across public health and OHA, as well as our partners in the community, to ensure that we had a coordinated response to this effort. As of earlier this week, there have been over 80,000 cases of this virus worldwide, with 53 cases and now an additional case in California in the United States. But again, as Director Allen said, 0 cases in Oregon. When public health is faced with a novel or new virus or infection in humans, we try to address a few things to determine how we respond. We look at how transmissible the virus is. How easy is it for the infection to go to one person from another? The information we have on this virus is it behaves very similar to a flu virus. So if someone is nearby, usually within 6 feet, and you have contact with that person, they cough or they sneeze, they can transmit that virus to you. For everyone who gets this virus,
An example.
That's why everybody here has been sick.
For everyone who gets this virus, is anticipated 2 to 3 other individuals would get this virus if we did nothing else. So it's behaving like the common influenza virus that we see every year. We also look at how serious this disease is and who it impacts. In terms of impacts from this disease, we see that the most serious complications tend to be in those older adults and in adults who have underlying health conditions. While this can impact children and young healthy adults, as can influenza, it isn't predominantly seen in those groups. It is seen in these older groups and those with underlying health conditions who have the complications from this virus. We also look at kind of what is that rate of complications. What we're seeing outside of China right now with the latest data is that less than 1% of people who get this virus die. And while that's still a very high number, it's lower than the numbers we saw come out of China initially. And that fatality rate really depends on a lot. How early do we identify someone who's sick, and what is their access to health care? So we anticipate that number would be even lower here in the United States. But we have not seen any fatalities here in the United States. And lastly, from a public health perspective, we look at what tools do we have to combat this virus or this new infection. In terms of COVID-19, we do not have a vaccine, so we can't prevent it in people with a vaccine, and we do not have medications to treat the illness that could shorten the course. What we do have are some very tried and true, some may say low-tech interventions, but that's things like covering your cough or sneeze if you're sick, washing your hands often, washing your hands after you cough or sneeze, and if you're feeling sick, we ask you to stay home. That's the best way to prevent spreading it to people you work with, people in your community, is to stay home until you've recovered. These are the tools that are working to control the disease right now. The federal government, in cooperation with the states, has implemented steps to try and prevent the spread of this disease into the country with the screening of folks who enter our country from China and other areas now that are infected by this virus. We continue to monitor those patients from China, as Pat said, and we could implement other tools as needed if this virus spreads. We receive these notices from the CDC daily, and we work with our local public health authority partners to contact these folks within 72 hours. So far, everyone has been compliant with our treatment, is staying home, and is reporting symptoms as they develop them. And as Pat said, 2 people developed symptoms while they were under monitoring. We did tests on them, and they were both negative. Those tests are currently done at the Centers for Disease Control Laboratory. We do anticipate that our federal partners are releasing the resources we need to do those tests in the Oregon State Public Health Laboratory. Some initial preparation has already begun at that facility in Hillsborough, and we anticipate over the next couple of weeks we would be able to run this test right here in Oregon, and that will help us as we ramp up our response. Because of the case in California, which did not have a known link to someone who traveled or to a person who had confirmed COVID-19 infection, we have broadened our definition of who we would test and who we think might potentially have this infection, from those who had traveled to an infected area to those who are hospitalized with severe respiratory illness who don't have another reason for that test. We would consider them a possibility for having COVID-19, and we would get that test to assure whether they did or did not.
If I could just add quickly before we move on to the next slide, a number of you I know have been involved in budget discussions where we've talked about modernizing public health, and it's sometimes been a little bit difficult for us to describe exactly what this is. Well, this is what this is, this capability at the local level to engage in monitoring, more epidemiological resources around the state for contact tracing and those kinds of things. Being able to respond in a situation like this is exactly what you've been buying with that investment.
So I'd now like to turn it over to my partner to describe some of the activities we've had in place.
Great. Good afternoon, Chair Salinas and members and guests of the committee. For the record, my name is Akiko Saito. I'm the Director of Emergency Operations at OHA. One of the things that's really important to note is, as Dr. Seidlinger mentioned, it's really important that we have local resources, because that's how we're actually working on the monitoring of all of the folks that have been coming back as travelers. And the really important part to say is that we did this in Ebola. We had 153 people that we did do through the monitoring system, and they were successful and were 100% compliant. So this is in place, and we're working really hard with our local partners to ensure ensure the safety of Oregonians. The other piece is, as Director Allen had mentioned, we have an incident management team together at the Oregon Health Authority. We work very closely with the Office of Emergency Management, and we have instituted a joint information center, which we meet on a biweekly basis. That's representatives from our hospital public information officers. It's our local public health authorities, our tribal members, and also our other partners, such as the Oregon Department of Education. The other important piece of this is that we are prepared to meet potential medical surges because we have instituted the Oregon Crisis Care Guidance. This is a framework for crisis healthcare that we've worked with multiple partners. The Oregon Association of Hospitals and Health Systems has worked within our healthcare system, and we have actually developed this framework for these types of incidences. We know that we're not at that point, but we are very confident that our health system can use the framework in order to respond. And things that we might look at is potentially canceling elective surgeries, which we saw potentially in the eclipse. That's what the framework provides for our hospital partners. And then the other piece is that we have a very robust healthcare or hospital preparedness program. We have 7 different coalitions across the state. And for instance, our Portland metro area, which houses the 2 Trauma One centers, their hospital preparedness organization is working very diligently. They put a multi-agency coordination group together, and they're making policy decisions such as patient visitation policies in order to meet this particular coronavirus response. And then finally, we have infection control guidance that we have been sharing with our ambulance services. We already have a very direct connection with our EMS and our 911 folks. We're working with, again, the Office of Emergency Management to ensure that emergency managers at the local county level are able to ensure that their 911 centers and their EMS folks are ready to respond and have the correct information.
So we're very active in providing information and education about this out in the community. We have a significant website investment at healthoregon.org/coronavirus that's got information for the public, information for providers, and those kinds of things. I actually happened to kind of field test this a little bit this morning. My daughter happens to work in a primary care clinic, and I asked, so what do you do? How are you responding to this? And she talked about how, well, when someone calls, they screen them based on their travel and their symptoms. And if their symptoms are mild, they recommend they stay home. If they're severe, they send them to the hospital. If someone shows up, they've got personal protective equipment. They've got a room that's got an outside entrance that they use so they don't come through the waiting area. And so all the things that you would expect are the things they've used these resources to be able to put in place. We've also activated our 211 public information line contract with information for those staff to be able to respond to public inquiries about coronavirus. We've got materials that have been translated into multiple languages, and so we're trying to make sure that the communication is widespread, and we're trying to work to counteract stigma, fear, and suspicion. We know people are concerned, and it's right that they be concerned. What we want to do is turn that concern into people being prepared with their families, their workplaces, and those kinds of things, and not have it turn into fear that causes other things that aren't helpful. Last thing I want to touch on, and Ms. Saito touched on this as well, we have in fact been here before. H1N1, Ebola, Zika virus. This is a system that we didn't just stand up for COVID-19. It really does date back at least to H1N1, which we had a significant presence of in the state. And as we've gone through each of these other circumstances, that system has gotten more robust and been tested. And so this is a system that, while it could certainly under certain circumstances become overwhelmed, I don't want to downplay that. We think it's very robust. And if this, in fact, as Dr. Seidlinger suggests, could end up looking like a really bad flu year. We've had really bad flu years, and we've been able to manage them with the resources that we have. We've got some direct tools to use as well in the event that we were to declare a public health emergency. And that includes things like court-ordered quarantines, eliminating large public gatherings, those kinds of things. Again, back to history, we've gone through H1N1 and other bad flu years and other diseases without ever needing to get close to triggering those kinds of tools. So while they're out there and available, it would be really extraordinary to need to go to that length. We do have some challenges that we're dealing with around supplies of personal protective equipment. There's a global shortage around that, not surprisingly, partly because of demand in China and elsewhere, and partly because the supply chains themselves often involved China. And then right now, as we sit today, our testing needs to be done by Centers for Disease Control and Prevention, which means shipping tests off to Atlanta or samples off to Atlanta for testing, and that creates some time delay. Today, that delay is not terribly significant because the number of tests being performed is pretty low. If that starts to increase, that could become a bigger problem. Now, CDC is working to get testing materials and supplies out into local communities, and we anticipate that shortly. But until that happens, if we end up with an increase based on these new criteria of testing, that could be a bit of a bottleneck. Oh, and then the last thing, just, and again, we touched on this earlier. It's going to sound to people when we say, well, what do I do? Wash your hands and cover your cough and stay home if you're sick. For some folks, I think it's going to sound a kind of low tech, and that's, really that's it. And really, that's it. Those are long-term, low tech preventive measures that work. And if people do them, it will really help. And there's all kinds of work being done on a vaccine and those kinds of things, but for right now, those are effective measures, and we really strongly encourage people to use them. With that, we'd be happy to answer questions you might have.
So as committee members can see, there is Purell up here on the dais. Let me just start off by asking one question. It's somewhat high level, and I was on a call yesterday with the Council on Foreign Relations, and I asked this of them as well. They had noted that the federal government has about $2.5 billion to address the outbreak, but only about $1.25 billion is new dedicated funding. The rest is reallocated funding. What is, first of all, will that trickle out to states? Will there be a grant program? What will that money be used for? And what I asked them, and they gave me a very political response, was, is it enough? And what will be the responsibility of states to take this on kind of ourselves if a worst case scenario were to happen, or even, more than just a maybe bad flu year kind of case?
Yeah, so Chair Salinas, members, let me tackle maybe the high-level question and then ask Ms. Saito to talk about some of the details of how that kind of resource flows out to the state. To the question of is it enough? There are a lot of questions, and that would be one of them, that are going to be very hard for us to answer until and unless we actually have the disease in Oregon and see how it behaves and how prevalent it becomes. If it's isolated cases that are easily traced back to their sources, and we can use self-isolation or self-quarantine to stop infection, that's one thing. If it becomes very widely prevalent in the community, that's another. And until we really have a sense of that, it's hard to answer a number of questions. It's easy to answer a question about how those kinds of resources flow to communities, and I'd ask Ms. Saito to comment on that.
Sure, thank you. So we actually have a mechanism that CDC put together after we've had a couple of crises, and it's called a crisis grant, and we did go before Ways and Means and did get that crisis grant application approved. That is how the money would flow. It would come from CDC to the states, and then we would, we would send that out to our local partners and our tribal partners the way we normally do public health emergency preparedness funds.
Great, thank you. Representative Kenny Geyer?
Thank you, Madam Chair. I had a couple different comments, and then I'll end with a question. One is I just want to say hats off to Representative Mitch Greenlick. This is his last session. He's been a big supporter of public health modernization, and I know that the legislature has not given him all the money. We've made a start on that, and we would arguably be even farther ahead with our infrastructure had we fully funded it, and I hope that this body will continue to fund that in the future. A little bit related to that, I'm hoping that you can use some of those dollars not only for monitoring, but also to make sure that we push out anti-smoking, because I've heard, and I'd love confirmation from the doctor, about the correlation between people who have respiratory, often related to being smokers, which is a higher rate in China than here, creating a higher rate of fatality. So not necessarily a higher rate of catching the virus, but certainly a higher rate of complications from that. And so I would think, if that's true, and I'd love to hear your opinion, I've been hearing this on the news, that we would want to do everything we can to help people stay healthy, have their immune system strong, and this might be a great opportunity for us to give yet another reason why we want to encourage people to quit smoking. I know that the rate of getting cancer goes down dramatically even among smokers after a year. So I wanted to make a couple other comments because I want you to be able to comment on several things. Related to staying healthy, we do have a bill that is sitting in the Senate waiting for a vote, House Bill 4029, which is a bill that was the chair brought to this committee as a committee bill to make sure that people who had an immigration status waiting for their citizenship would not feel like they would put that at risk with some recent federal rules around public charge. I hope that we are able to pass that, because I do really fear that people who are worried about that will not be coming and seek the help they need when they start feeling sick, and they won't show up and get monitored, get tested, and this could be really dangerous. I say the same for the undocumented population. This is a time where we need to all think about how we can keep everyone in Oregon healthy, whatever we can do as a legislative body. And I will say, I hope the Senate Republicans and House Republicans come back, because this is not the time to walk out on our jobs. This is a huge crisis, and we have a lot of bills in the balance. We're waiting to be able to pass more money to the E-Board to give OHA more money to use in an emergency situation. So there's a lot of comments in there. I guess the part I would love for you to react to are, you said all we can do as individuals is wash hands. Well, there's a lot more we can do as a legislative body. There's a lot more you can do as public health in terms of how do you push messages out to people, whether it's anti-smoking or other ways to keep healthy within the limited resources that we've given you to date.
Yeah, so I think in addition to those messages about washing your hands and covering your cough, the things that we can do as individuals to stay healthy is to be healthy all the time. If you're healthier, if you have diabetes and your diabetes is under control, you're more likely to be able to successfully fight off a virus and maybe have a mild case and not develop complications. While I haven't seen science that specifically links smoking to this disease, we do know that
or to higher rates of fatality to this disease.
Smoking, even in the shorter term, does impact lung function and the ability of our lungs to function properly. So if someone is smoking and has a negative effect, it stands to reason that they might not be able to fight off the disease and might have more serious complications. So again, not smoking is part of that. Eating right, not smoking, taking care of your chronic conditions, that helps keep you healthy and makes it more likely that you're going to be able to fight off a new disease or a common disease like influenza when it comes into our community. So the efforts we can do to help people stay healthy, I think, are very important.
And if I could just add on the public charge issue, small but important point is that the program we have today for people who do not have citizenship status to receive emergency medical treatment is not affected by the public charge issue. And so people need to know that if they need emergency care, they should pursue that emergency care regardless of their status.
I just hope we're getting that message out, because people are very fearful right now.
We're working very hard on that issue.
Thank you.
Representative Wilkie.
I guess I had a question. I think I heard maybe the same report you did, first of all, that because rates of male smoking in China are significantly higher than for female smoking, the mortality rates have been significantly higher. So let's throw that out there. My question is more, I'm going through the crisis care guidance. My concern was, it looks like the governor does have the authority in a declared public health emergency. And I felt like we've talked through sort of the wash your hands public information level, and I feel like through various exercises I've been on, we've gone through the isolation and quarantine piece of small numbers of people. What I'm seeing coming out of China and Japan is more social distancing guidance as a way of slowing the spread and managing the risk. I see that is part of the guidance here. Can you maybe walk me through if for instance, you advised the governor and she decided they needed to close schools or go retail to delivery only in a certain area, how would that decision get made and how would it be implemented based on how we're set up right now?
Let me take a crack at decision making.
Dovetail on that question a little bit. What would the communication process so that we are knowledgeable as well as our local community health officials as well as our school districts kind of that coordination of communication.
Yeah, so thank you, Chair Salinas, Representative Wilde. As you may have seen today, or I think I mentioned, the governor has convened a coronavirus response team that's made up of about a dozen agency heads of either agencies that have a significant role in dealing with the event or may have a significant population at risk, corrections, youth authority, that kind of thing. That body is created to basically advise the governor on those kinds of decisions. We meet right now weekly. We can certainly increase the pace of that as circumstances dictate. And what I would expect is if we get to a place where, unlike circumstances like H1N1, we get to where the prevalence of the disease is outstripping our resources and our use of the usual tools to fight that group would take up the issue of whether the governor should declare an emergency, make a recommendation. We would be all over the place here making you aware of the decision-making process and what's going on in that. And then if we got to the place of declaring a public health emergency, our communication would be truly robust across a variety of channels to make people aware of that and the specific actions being taken. Anything we need to add to that?
I would just say the crisis care guidelines you reference are really some tools we have for working with our healthcare partners to try and make sure that we can increase the capacity within the system during a crisis. Some of the efforts for social distancing and other things you reference aren't in those crisis care guidelines. They're in a separate document. We have a high impact pathogen plan of operations, the HIPPO, which are outline some of the public health tools that Director Allen mentioned about social distancing, cancellation of events, closures of schools or other large gatherings, if it rises to that occasion. And we come back to you and the governor to say that we think that implementing those solutions would be helpful in controlling the spread of disease. So we do have those outlined in another document.
And if I could just make a comment on school closures, because I know that's been in the news with the decision Japan made recently. Most folks, I think, don't know, we close schools for health reasons every single year. An individual school may close for a period of time due to norovirus or influenza, and that's a decision that gets made in consultation with the local public health authority and local school district, and that's done without there being a public health emergency or anything like that. And in a circumstance like this, we could certainly, that would be our first line of dealing with issues at the school level. We would need to get very far down the path before we would do some of the broad things that we've seen recently out of Japan.
Yeah. Representative Prusak.
Thanks, Chair Salinas. I want to echo what Rep. Kenny Geyer said about the importance of funding our public health department, on top of making sure that you all are prepared to fight any infectious disease. I think we'll also have to be prepared in the future for things that come with climate change. My question is probably for Ms. Sato. I know you mentioned that you've been in touch with hospitals about making sure travel, if visitors have traveled, that is something to consider when they're visiting. Tomorrow and Sunday, I will spend my time in long-term care facilities, assisted facilities, memory care, and so I'm wondering if that's also being verbalized to them or communicated to them, rather.
Yes, Representative Salinas and Representative Prusak, thank you for that question. That's really important, and the work that we have been doing with our coalitions, they do include long-term care facilities, but that is something that we need to be really cognizant. And earlier today at the coronavirus response team, it's just newly formed today, that the governor activated, that was one of the questions, was long-term care facilities and then also state institutions that have people who can't leave. So those are really important issues that we definitely need, and we're taking this time right now to brush up our plans and make sure that we have all of those folks, especially vulnerable populations, in mind.
Yeah.
So thank you for that.
And we do have significant experience in past incidences focusing on specific vulnerable populations. Influenza and long-term care is a good example. Shigellosis and homeless encampments is another. And so we've got experience responding to an emerging need that needs to be tailored to a particular population or area or something along those lines.
Thank you.
So I'm just going to jump in before I call on Representative Alonso Leon, because continues this conversation a little bit. Representative Gomberg was here. He had to leave. He was in the audience. But so just talking about some specific populations or areas, the coast, a third of the coast, we have populations over 65 years old, and a lot of them are not in care facilities. They're actually in individual homes. What would a response system kind of look like out there? And then, and have you thought about like the potential effect for tourist areas like the coast?
Do you want to take that?
Thank you, Representative Salinas. That is a great question as well. And one of the things that we've worked with Representative Gomberg and also our coastal communities around sort of the Cascadia earthquake planning. And so one of the things that to note was at the Curry, in Curry County, when we had the Checo bar fire, that was one of the biggest things was we knew that 60% of the folks in Curry County were Medicare patients and over 60. So that's something that we have experience in doing, and we definitely will work with our local public health authorities and our coordinated care organizations to really identify where those folks are and then to ensure that they have what they need as far as resources. We have a ability to pull CMS data in an emergency so that we know where those folks are who are not in a long-term care facility, and so that we can then, for instance, in the Checo bar fire, we pre-positioned EMS services near the population that we knew from pulling that CMS data. We knew where those folks were, and we ensured that we had the EMS mobilization units there in order to evacuate those particular vulnerable populations.
And if I could just expand on that, not only did we know who was on Medicare, but we knew things like who had mobility issues or medical gas issues or those kinds of things from further data from CMS to help us manage those issues specifically.
Great, thank you. Representative Alonso-Leon.
Thank you, Madam Chair. Thank you for the information today. Really valuable as a starting point, and we just need to be prepared for any situation. I am particularly wanting to know what your communication plan is to our non-English speaking community members, folks who live in rural community who don't have internet and can't access the website for information. We have to remember that there's a lot of members of our community who come from Latin American countries, who are indigenous, don't speak Spanish. And so I just want to know what the plan is in respect to making sure that there's an outreach plan with them to ensure that they have the information. And also, I think this goes along with our crisis care guideline also, and I'm curious to know, and I'll talk to my colleagues later about their plan in respect to communication outreach to our non-English speaking populations in Oregon.
Salinas, Representative Alonso-Leon. The first line of communication around these kinds of issues would be through Spanish language media. As you observe, Spanish is not the only language to be concerned about. As we think about ramping up this response now, as the governor has directed us to do, that further outreach would be part of what we would develop immediately to begin to push out those messages. You reminded me also of one thing that I neglected to mention earlier, which is one of the things that may occur in a circumstance like this are asking people to stay home for 2 weeks, and that could conceivably become widespread, even if it doesn't. And it actually ties in beautifully with earthquake and other emergency planning. What are you going to do if you're stuck at home for 2 weeks? Mm-hmm. Do you have food? Do you have water? Do you have all the kinds of things that you should be prepared with in any case? And so this is yet another reminder to anticipate those kinds of issues. But to your core question, we can come back with the more detailed outreach plans that will go with this ramping up of our preparedness response.
May I follow up, Madam Chair? This is really important. We assume that because we have these, we have press releases, we have these conversations, that we're talking about it, that everybody's getting the message. That is not necessarily true. Mm-hmm. And so as we think about preparing for something as serious as this, we need to be considering all kinds of ways of making sure we have information that's reaching out to all of our communities in the entire state. I think back with Salem's water situation. I got on the call like all my fellow legislators, and there was a question about, did we communicate to our non-English speaking communities about the water situation? And we found out that that was not necessarily the case, that it took some of the school districts to send out information to families. I really want us not to do that, right? I want us to have a complete plan that is inclusive of all of our community members. So I am looking forward to your plan that is inclusive and is very mindful of all of our communities, especially in the rural areas where we don't have internet, but we do have radio, we do have other means of making sure that they have the information that's necessary for them.
I completely agree, Representative. And since that Salem incident, we've adopted as a core performance measure our translation and the speed of our translation of documents. We've brought the community partner outreach program back into the agency, and their relationships actually in a circumstance like this would probably be one of the most key elements of a plan like that, but we'll be happy to come back.
And as part of our incident management team, we have a liaison team with folks who are communicating regularly with our community partners and those outside of OHA, because we know that through some of our mechanisms like media and things, we can reach some people, but it's those partners in the community that know the best way to reach their community. They can tell us what we need to do to change that and can also carry that message out to their community themselves. So we do work on multiple levels to try and reach everyone, and we continue to improve and strive to improve.
Thank you. Representative Evans.
Thank you, Chair Salinas. I have two questions, and I want to be very clear so that they're not taken out of context. I know we're not anywhere near this point yet, but during the H1N1 process, I was actually working for Governor Kungaski, and there was a few moments where the idea of capacity and what people think of in terms of hospitals and things like that met reality. In a big picture sense, how many, let's just say, patients that are either under direct checking to see if they actually have it or, in fact, have it, what is the surge capacity for the state? How many people actually would be putting us at the part where we're actually needing to get help?
So are you speaking from a Chair Salinas, Representative, and from a public health perspective, we have a public health system that includes our tribal and local public health partners as well. And so both within the state and within those systems, there's the ability to pull additional people, often into a response. So right now, the active monitoring of patients who are under monitoring requires daily calls. If those numbers increase, we may get to a point where there's kind of less frequent calls, but for those who have been compliant, because we've seen really good compliance across these, and we would continue to try and we have emergency responders that we can pull in within OHA and within our local public health authorities to expand the workforce on a temporary basis to respond to a crisis like this.
I would hesitate to want to try to give you a number, not because I don't want to be transparent, but because inevitably in a circumstance like this, as it develops and worsens, the system, us, hospital systems, other healthcare providers, local public health, tribes will shift and respond and adjust our response to meet that. And anything I would try to come up with as a number now would be almost completely hypothetical and not reflect on that. The other really important thing to remember is that we do not have evidence that this is that our context should be everyone's going to get this if it becomes present in the state. Everywhere that it's been, it continues to be a very small percentage of people who get it, and an even smaller percentage of that who become seriously ill as a result. So there's nothing on the horizon out there as we see this today that leads us to automatically think that that's the horizon we're headed toward.
So let me try this a different way. Sure. It was an interesting lesson to find out how profit-driven hospital care is in many ways. What are the total number of beds in the hospitals in Oregon?
So, Chair Salinas, Representative Evans, we can, unless someone here happens to know that number off the top of their head and they're shaking their heads, we can report that number back. But back to the responsiveness, we are not necessarily dependent on the beds that are in those hospitals and have the capacity. Under the systems, we have to create basically more hospital capacity if that becomes necessary.
Understand, but I'd appreciate that information.
Sure.
Yeah, we'll get that information back to you, of course. Representative Scouten, did you have a question?
It was just kind of, thank you, Chair. I'm trying to imagine if this, has a big impact. Citizens are going to say, I want to be tested. And in reality, being it's similar to flu, it doesn't really matter maybe if that they get tested, that they just stay quarantined. But if people wanted to get tested, what I'm concerned about is everybody flooding urgency care centers and they're making everybody else sick. How are you going to handle the testing, and where would the testing take place?
So currently, the testing is an important part of trying to identify cases, as we know that it's very rare in the United States, and even rare as we've had no cases in Oregon. So that testing becomes important to try and identify those initial cases so we can respond and try and contain them. We anticipate that as the people who might potentially have this disease increases, that our testing capacity will hopefully increase as well. But it doesn't mean that everyone needs to be tested. Right. If someone is sick and has mild illness, even if we know this disease is widespread in the community, the message really isn't to be tested. It's to stay home, limit your travel so you can recover and not infect other people while you're sick. And we'll continue to have to put that message out because there is fear around this disease. It's new. People will want to be tested, and that's not necessarily a case that everyone will need to be tested. So we'll have to continue to do that message and prioritize with our healthcare partners that those who need to be tested, who have the highest priority, who are the sickest, get those tests and reserve the capacity there.
And if I could just take advantage of that topic to maybe pile on a little bit, 22,000 people this year so far have died of influenza in the United States, and we can't get the vaccination rate up above about 40%. So if you're really concerned about what can you do to preserve your health and minimize risk, it's not too late to get your flu shot.
Mm-hmm. Thank you. All right, I have a question from Representative Power. She just wants to clarify that there are no drinking water impacts. And then, is there a chance that municipal workers would have to stay home from drinking water operation facilities?
So this is not a virus that's transmitted through the drinking water. It really is transmitted from person to person via droplet secretions. I think in the municipal drinking water, I would say the same thing we would say to all large employers. We should all, whether we're state employees or other employees, have a plan for what to do in the case of a crisis or an emergency. If an event would disrupt the normal work operations, how could people work remotely? How could people do their business in another way that doesn't involve people coming together? And hope that our water systems, similar to our healthcare systems and others, have those plans now in place so that if it comes time that this is impacting their workforce, that they have plans in place to ensure that critical operations are done and maintained.
And state agencies do, in fact, all have those kinds of plans in place. And the governor, actually Department of Administrative Services yesterday asked every agency to review those plans in the context of this potential outbreak and make any changes that were necessary.
So you just mentioned the people-to-people contact, and stories from, I don't know how long it's been now, 2 weeks or so ago, had mentioned that water markets or wet markets were kind of the genesis for where they thought that maybe this started in China. Is that not the case, that there's no animal-to-people transmission?
We don't know the actual origin story of this disease, but often with new infections that are introduced to humans, they are zoonotic or come from an animal. The information we have out of China hasn't given us that definitive answer yet, but what we know is that this disease is now in our communities in countries across the world, and we can see that it's transmitted fairly easily from person to person. So that's what we see causing the spread of the disease right now, and that's why we as public health are encouraging people to take steps they can to prevent that spread from person to person, staying home when they're sick, washing their hands and covering their cough. Again, low-tech solutions that Director Allen said are effective, and so we should be using them, and we continue to recommend their use.
Thank you. Representative Kenny-Geyer.
Hi, I just wanted to say that Andy Easton is on tap. She's the Hospital and Healthcare Association, Health Systems. She said that there's 6,664 staffed hospital beds. 55% of those are in the metro area. And she is available if we have other questions about this.
Great. Any other questions of this panel? Yes. Representative Alonso-Leon. I think this has to be your last one.
Thank you, Madam Chair. So this panel has used virus, infection, and disease simultaneously. Can you, I think it's going to be really helpful for you to articulate or explain what each of those three, what the differences are, so people, in the community know if there is a difference, and how can, when people talk about this infection, virus, disease.
Let me take a crack at this just to see if I've been paying adequate attention, and then Dr. Seidlinger can correct me if I get it wrong. A virus is an organism that is a living thing. And infection is when that organism enters into, in this case, a human. And a disease are the sicknesses that result from the infection by that virus. Yep.
Director Allen gets a star. But I think we can ensure that as we put information out, that we have some of those explanations that perhaps we take for granted, kind of laid out about what this is, why we're concerned, and the steps that people can take, and how that will protect them.
Thank you.
Well, we know this is just the start of the conversation. Thank you for being here today, and thank you to our guests for joining us.
Thank you.
Next up, we have Jeremy Vandehey,
So can you follow up with my question?
Analytics Division, Oregon Health Authority, an update on SB 889.
Okay, can you let me know what you guys have?